While endometriosis can cause pain and infertility, many women with endometriosis actually have no symptoms at all. That's just one reason that the medical community is awful at diagnosing endometriosis.
Even women with debilitating cases of endometriosis often go nearly a decade before a doctor finally diagnoses it.
A lot of doctors dismiss a woman's pelvic pain as being normal, when in reality, there may be something wrong. So there's a good chance your doctor will just cast aside your complaints.
In that case, you may need to become more insistent they screen for endometriosis or start looking for a new doctor.
There's a real myth that it's, quote, normal, end of quote, for a woman to have really serious pain with her periods, and that's just not true. It's certainly true that many women have a small amount of cramping with the menstrual period because of a hormone called prostaglandins that can cause cramping to occur at the time of the period. But a woman should not be disabled and put in bed and not able to go to school, go to work, do activities of daily living, exercise when she has her period. There isn't the awareness either among patients or among many in the medical profession that this is a serious problem that you need to think about. When a younger woman, often these women are younger, of course, when they come in and say, oh, well, you're healthy, you're going to be fine, when that's not the case. So we really have to raise awareness among women and say, no, I have a problem. Could it be endometriosis? And then after this happens, it's very important for the woman to either find the doctor, if she does on her own, who knows something about this disease, or to really insist on getting a referral to somebody who does understand this disease and can help her with a diagnosis and treatment plan.
While endometriosis can be hard to diagnose, there are clearly some risk factors for who is more likely to develop it.
That includes women who have a family member who's been diagnosed with endometriosis, those who had their first period at an early age, women who have short cycles, women who experience migraines, and women with a lower than normal body mass. Diagnosing endometriosis can be tricky, and there are trade-offs for each of the methods, namely undergoing surgery, a physical exam, a transvaginal ultrasound, or an MRI.
Let's start with surgically diagnosing endometriosis.
This involves doing a full-on surgery to try and see and remove cells that can be confirmed to be endometriosis. For decades, this was how endometriosis was diagnosed.
The benefit of surgery is that it's the most accurate method we have to diagnose endometriosis.
Surgery also allows the doctor to inspect the fallopian tubes to make sure that they're open. That's useful because the tests normally done for that are wrong a quarter to a third of the time.
If a woman's tubes are in fact closed, she must resort to IVF, and knowing this definitively and early on would be a major help.
What's more, diagnostic surgery can help doctors remove the endometriosis. However, that can also be a problem, especially if endometriosis is on the ovary, and we'll cover that shortly.
Lastly, surgery allows the doctor to give the endometriosis a stage of severity. But be warned that staging does not correlate with how likely or unlikely a woman is to conceive.
So given all of the benefits of surgically diagnosing endometriosis, why do so many doctors and societies think it's a big mistake to do a lot of surgical diagnosis of endometriosis?
Many see it as total overkill and believe the 2 to 6 weeks of recovery time is far too burdensome, given that there are cheaper, easier, and reasonably reliable alternatives.
A woman who has really serious issues with endometriosis should get a definitive diagnosis so that the appropriate intervention can be taken at that time. And I would also really like to emphasize, because this disease occurs mostly in younger women. I mean, they're 20 to 30 to 35, but it's a disease that's going to be with them until the end of the reproductive years, around menopause, age 50.
And if you do have surgery to diagnose endometriosis, be sure the doctor is prepared to take a sample and have that sent to a lab to confirm it's really endometriosis.
Yes, some doctors can just eyeball the endometriosis and give a diagnosis. But if you're going to the trouble to have surgery to be certain, there's really no reason to chance it.
The general recommendation, of course, is that every patient who has a laparoscopy for whom endometriosis is seen should have a biopsy done at that time by the surgeon. They should use a little pair of scissors or some other instrument to take some tissue out and send it to the pathologist. But it's not considered absolutely essential to have that, because endometriosis, most of the time, if you actually have it, the surgeon should be able to tell that you have it. However, it can be difficult to diagnose. And again, if a surgeon has done thousands of cases of endometriosis, they can probably be pretty accurate in saying, yes, it is endometriosis, or no, it's not. But even experienced laparoscopists who've done thousands of cases will make mistakes sometimes.
As we quickly mentioned, when doctors surgically diagnose endometriosis, many want to treat it right then and there. If the endometriosis is on the ovary, that doctor may be taking risks with your fertility.
We'll deal with this more in the next lesson, but if your doctor wants to do surgery to diagnose endometriosis, make sure you know if they also intend to treat it at the same time. If so, pay close attention to the next lesson, where we'll cover how surgery to treat endometriosis can actually pose a risk to your fertility.
And to be clear, diagnosing endometriosis with surgery certainly can have value. For women who suffer with symptoms for years, getting a definitive diagnosis can be helpful.
An alternative to surgery would be to go by a patient's symptoms, accompanied by a physical exam. Some of the more common endometriosis symptoms include pain at varying times, like during periods, intercourse, or bowel movements.
That pain can occur in the pelvis, shoulder region, or elsewhere. Other symptoms include continual fatigue and, of course, the inability to conceive.
Taking symptoms and doing a physical exam is quick, easy, inexpensive, and can be done by most women's health doctors. But again, that doesn't mean all doctors are willing to give this process the attention it deserves. You may need to insist.
And in competent hands, a physical assessment is generally pretty accurate if the endometriosis resides on the ovary. So if your doctor says there's endometriosis on the ovary, or says there's no endometriosis on the ovary, there's a good chance that they're right.
And for fertility doctors that believe endometriosis on the ovary is really the most problematic from a fertility perspective, often a physical exam is good enough for them.
But there are doctors who think endometriosis lying elsewhere on the pelvis also impairs fertility. And unfortunately, physical exams are not nearly as good at determining if endometriosis exists there.
Doctors can use a vaginal ultrasound to diagnose endometriosis. Compared with surgery, this approach is pretty cheap, and since most fertility clinics make this part of the standard workup, it's accessible to a lot of women who are struggling to conceive.
While ultrasound is generally more accurate than a physical exam, it suffers from a similar weakness. It's solid at determining if there's endometriosis on the ovary, but much less reliable at determining if endometriosis is anywhere else on the pelvis.
How relevant is that from a fertility perspective? Well, for fertility doctors who think endometriosis on the ovary is really what hurts fertility, many can live with ultrasound's shortcomings.
For those who think endometriosis on the pelvis can really hurt fertility, they underscore this as a clear issue with ultrasound when trying to address endometriosis to improve fertility.
With better technology now and with good ultrasonographers, it is becoming possible to diagnose this deep endometriosis. I want to emphasize, though, that ultrasound cannot be used to rule out endometriosis, because endometriosis that's on the peritoneum or adhesions or scar tissue that comes with endometriosis will not be diagnosed by ultrasound most of the time. There may be very few situations where it can be found, but as of today, the ability of ultrasound to pick up what's called peritoneal superficial endometriosis or adhesions is exceptionally limited, and it's really not useful for that type of endometriosis.
Another method to diagnose endometriosis is through MRI, but in reality, it isn't much better at diagnosing endometriosis on the ovary compared with a physical exam or ultrasound.
But where MRI excels is at diagnosing endometriosis for women who have pain in their bowel and intestines. This is where MRI beats physical exams and ultrasounds.
MRI can also be crucial in diagnosing rectal or bladder endometriosis and planning the surgery to remove it, which can require a lot of forethought and preparation.
An MRI can certainly be helpful to look for deep endometriosis. So especially when one is planning to do surgery or considering doing surgery, an MRI can help to determine the extent of the endometriosis and whether it might be necessary to operate on the bladder or the bowel or around the ureters. And so the surgeon can help to plan and be prepared. Maybe they need to have a colorectal surgeon with them or have a urologist with them who will work on the bladder. They can also help to give informed consent to the patient about what's involved here. And you can use the MRI to identify the extent of the disease and to help correlate that with the symptoms. It can be very, very helpful where you have a lot of disease and you're trying to get more detail about exactly how you're going to approach the treatment for that patient.